She's just whispering to me 15 minutes. I don't know if that's enough time, but we'll try and see. As you've heard, I'm Hellen. I was attached to the Ministry of Health, and as you are trying to find out what gaps the ministry has so that we could do a project or do a project on it, this area was that which the ministry was concentrating on at that particular time. They are in the process of actually coming up with restructuring the Ministry of Health in line with the new constitution. So that's why my mentor and the other staff say that this would be an area where they could also benefit a lot. As I've just said that the Ministry is held, they're still in the process of restructuring the health system in line with the devolved system. And the current practice, actually the Ministry of Health has been decentralized for as long as you could imagine, maybe since independence when they started doing decentralization at different levels. But the form of decentralization that they were currently using is called deconcentration. Deconcentration is whereby the functions of the ministry and resources are transferred to a field office or a regional office. That's how government actually has been operating, through deconcentration, which is a form of decentralization. But now they are moving to another form of decentralization, which is called devolution. Devolution actually is the transfer of functions to local governments who have the political, administrative, and fiscal powers. The same local governments can raise their own revenue, they elect their own officials. So you see the scenario is going to change, and they needed to see if they could still use the same allocation criteria that they've been using or come up with new ones. So that's why I was coming in, and they tasked me to do that so that they could have a way forward on this. And another typology of decentralization, which is not here, that maybe for your own interest, is privatization. Privatization is whereby the government, a government actually gives autonomy, transfers its services completely to the private sector. Or another type is also called delegation, whereby the government transfers its functions to a semi-autonomous, public or private body to perform function on its behalf. So basically there are four practices. What we see now is deconcentration, and what is going to happen in future is devolution. And health resources, health workers, health facilities, health products and technologies are currently unevenly distributed across regions in this country. Now, the national government currently under the devolution, the devolved structure, has actually approved or has released 15% of the national budget to the counties. So this is what the counties is going to be using as their revenue from the government. The remaining 84 point, there's still remaining some 84.5%, which the government will be holding, but it still be releasing this money in form of maybe directly through the sectors. For example, the health sector will get some allocation, agricultural sector some allocation. The Commission on Revenue Allocation, the CRA core mandate, is to recommend the basis for equitable sharing of revenues raised nationally between the national and the county governments, and also sharing of revenue among the county governments. This commission is the one which is tasked with the duty of coming up with a formula that will ensure that this 15% actually reaches the counties. Now, once this 15% reaches these counties, it's the counties to decide how they're going to utilize this money. Yeah. And the same CRA also recommends on appropriation of money out of the equalization fund. I'm going to show you a slide that actually explains more of this. In addition, counties are expected to raise its own revenue and can receive loans or grants from the national government. If you allow me, let me just show you something here. This is a slide on the Commission on Revenue Allocation, and this is actually how they're going to share out the income that is raised. As you can see, the revenue that is raised nationally is 100%, and they raise it from taxes. They get also loans from outside or investment income. Now, this money, out of this 100%, 15% goes directly to the counties, yeah, to the county governments, for them now to also use across sectors. And the same counties will also be charged with the duty of collecting money on their own to supplement the income that they get from the government. And also they'll be receiving loans and grants from the same government, and there'll also be 0.5% equalization fund that comes from the main government that will go towards the marginalized areas, will go towards upgrading all those areas. For example, maybe health facilities, schools, areas that have actually been left behind, so that all counties can be at par. So these are the people of Kenya. They'll be receiving services through the county governments, the 15% revenue, and they'll still be receiving services through the remaining 84.5% from the national government. And I believe this money will still be going to the various sectors, the health sector, agricultural sector, and the money that the county government also uses will also be going to these sectors. So you'll find that it's a bit confusing. You cannot actually put your hand to know how the money will be leaving the national. There are various ways in which it is going to be reaching the county. So this man will be having revenue here. This county governor or the county government will be receiving income from various sources. From the main line, which is through CRA, also through the equalization fund, and then maybe through grants, through line ministries. So there'll be several sources of income. And that's why we sat back and decided that we need to define some form of system or guidelines that will guide this county, that will ensure that the county governments actually utilize the resources that have been allocated to them in the way they're supposed to. So the main objective of this study was to enhance allocation of health resources at national and county levels. Initially, I wanted to do just enhancing allocation of resources to the county governments, but they asked me, now, if you want us to do the county levels right now, what are you supposed to do now in the meantime? Because we still need to define some way, some form of system of even moving towards this allocation. So now that's why I decided to do some form of transition guidelines that will help them also to allocate to the county levels. The specific objectives was to review the current Ministry of Health resource allocation criteria that they have to their decentralized offices, and to develop the actual guidelines, and also to build the MOH staff capacity for implementing this guide. The methodology, I did a lot of desk review of the existing resource allocation criteria. They have a lot of documentation. They've been allocating resources. So now I had to review what they've been doing and see if it can still apply in the current system. And also I did a review of resource allocation in other countries, in similar setup, devolution in the devolved setup. Then there was also a lot of interviews with the Ministry of Health staff to get their input, their views, and also input from the MOH stakeholders. We held stakeholders workshops, 2 of them. And then we eventually trained the MOH staff on the guide. Now this is what the MOH currently has. They have, this is the criteria that they use to allocate resources to the provincial and the district hospitals. What happens, the MOH has a criteria that allocates funds for operations and maintenance. These are funds for operations and maintenance, and they also use it to put ceilings on the drugs, on the amount of money of drugs that a particular facility can actually obtain. So this is an allocation criteria for both the operations and maintenance, and also for the drugs that the facilities actually use. So these are the weights. The variables are poverty, beds utilized, outpatient cases, accident-prone facilities. These variables actually, they indicate how much a facility would need, yeah, as compared to another. So this would make the facility, each facility stand out, yeah, from another. So this is the current system they're using, and they also have a special variable. This special variable, they use it to allocate resources to the mental hospitals. They have Madare Mental Hospital, Gilgil, and the National Spinal Injury, and also the Pumwani Maternity Hospital. They also call it a special hospital now. So that, because when they use this criteria with those variables, without the special variable, they realized that some of these hospitals, they were losing out. Because like the mental hospitals and the spinal injury hospital, people go there to stay. They actually don't live. So you find that they don't have many outpatient cases. So when it comes to that variable of 0.2, you find that they actually miss out on that. Yeah. So they decided to add this variable so that these other facilities could be compensated for it. Now, after reviewing that, we realized that the special variable, all the other variables could stay, but the special variable could not stay because in the county setup, you'll find that Nairobi has 3 of the special hospitals. So it would mean that Nairobi would be burdened, more burdened than other counties. The only other county with a special hospital was Gilgil. So you'll find that this special variable, it would not make sense to leave this rack, for this rack to be used with the special variable for the counties. So now that's why they decided that the special variable can, the special hospitals can actually be funded directly from the national government. And they're revising their plan to accommodate that. For the primary healthcare facilities, the current allocation they use a flat rate figure of 450,000 for the health centers and 116,000 for the dispensaries. So they do it every quarter. Every quarter, they send a quarter of that money to the health centers throughout the country, regardless of how many patients, how many workload, regardless of the workload, they send a particular amount of money to go to these various facilities. For mobile clinics, which are mostly in the northern Kenya, they send that amount annually. Whether these people are seeing patients or not, they just send the money faithfully. Now, the problem with this is that it does not take into account the patient workloads. Some facilities have higher workloads than others. And also, some health centers actually offer the inpatient services for maternity cases. So it shows that they'll actually need some more money than others. So now this is what came up with. I put some criteria now that the county hospitals that can be used at the county levels. So you find that I put a 0.3 weight to the poverty levels for that particular county or that particular district where the facility is actually located, the under 5 population, the female population, and bed utilization. Now, these variables, they were used here because a study was done and it was found that the under 5 population and the female population are the majority who actually attend, who form the bigger chunk of people who attend the health facilities, the primary health facilities. And also, to be in line with what the Ministry of Public Health and Sanitation, they're trying to reduce the maternal mortality rate and also the under 5 population, under 5 mortality rate. So this was supposed to move towards also their targets, yeah, of improving these health outcomes for this population. So the bed utilization, I added it so that it could present it to compensate those facilities that actually offer the inpatient services. So from that, after revising their allocation criteria for the primary health facilities, we also came up with other guidelines or other specific steps that the counties, together with the Ministry of other policy directions, the counties could actually utilize. For example, now, out of all that income that the county will be receiving, we propose 15% of the total county income to be allocated to health in line with the Abuja Declaration. This at least will ensure that Kenya still remains committed towards this Abuja. I know right now we are doing about 8%, but at least if you go this way, when the counties also know that this is expected of them, at least we can be assured of moving towards the Abuja Declaration. And then also something that which is being done right now, they started doing it, but maybe now, okay, they have been doing it, but now they are concentrating now their effort on it, is the establishment of a health equalization basket. Although what they're doing is that they're just looking for donor partners who want to upgrade certain hospitals, but right now, it proposed for them to do a health equalization. Initially I proposed a fund, but they told me the process of doing a fund, they have to register in the treasury, it takes a long process. So they said it can just be some form of a basket, whereby MOH can get an allocation, the government can put in an allocation, the partners can also put in an allocation, and then they upgrade all hospitals and all health facilities as per the existing norms and standards. So that all hospitals, all health facilities throughout this country, they'll be at the same level. They have the same level of equipment, the same structures, so that by the time the county governments take over, or even as they take over, you're going to find that there won't be any inequality problems that we have that currently exist. So they are committed to that, they're already doing that. And then facilities also need to be strengthened on the efficient utilization of generated revenues. Now these are trainings that the MOH will be pursuing for the counties, especially the ones who will be in charge of looking at the revenues, who will be in charge of the financial and the planning aspect. The MOH will be committed to ensure that they are trained, they're properly trained on what is actually happening, and then the capacity in financial management, planning and budgeting, and then planning also to include now planning of this county, of the county health projects, to include sector-wide approach where donor resources are put together to help meet the budgetary requirements. So these county health teams, they're going to put all the donor funds that they get together, and then they're going to plan just what they've been doing right now. They're trying to put all the donor funds together so that if there's a particular project that one donor A is funding, donor B should also be aware of it, so that they can put their resources together and see how they can supplement and complement each other. So the same to be replicated to the counties, although some issues were being brought out of this because they say that they could not actually stop donors from recommending what they want to assist in counties, and they could also not stop county governors from striking deals with donors. But they say that is okay as long as the projects they are doing, they are moderated. There's some guidelines, there are some frameworks for them to actually do these projects. And those frameworks are actually what these guidelines are supposed to address. Now, also the strong monitoring and evaluation framework to be put in place so that the policy, actually, okay, let me just give a brief background on how the Ministry of Health now has been restructured. The only division which is going to remain at the Ministry of Health is the Policy and Planning Division and the National Disaster Control. So everybody else is going to go to the counties. So the policy people are the ones who are going to be forming policies and sending them to the counties, and also doing monitoring and evaluation of what they've actually formulated to see if it's actually being carried out. So these guidelines are for them. I was in their section, and they're also for the county government. So they're the ones who are in a position to ensure that these things are actually put in place. Now, when it comes to health products and technologies, currently they're centrally procured and distributed through the Kenya Medical Supplies Agency based on quantification of the needs of the facility. The facility has to send a list of what they need, and also based on a rack that allocates funds to inform them on the drawing lights. The rack is actually what I've presented. So this rack helps the facility to know how much they cannot go beyond. But what actually determines how much they get is what they put in a request for. Okay, we know there are current institutional problems with KEMSA, but they're currently being resolved, and they're also going to, no, they'll not devolve, they'll just deconcentrate, because they said devolution is a bit expensive for them, but they are there in almost all the regions, centrally, strategically placed, and they'll be able to issue or to supply these drugs when needed. Now, to ensure safety, quality, and cost effectiveness, you know that the issue of drugs is a bit emotional because you also have to ensure that those drugs remain the safety that the government wants, the quality. And you know, now this being a devolution, and I'm sure the county governors have already started seeing themselves as small presidents with state houses, and they can also buy their own drugs, you know all these things. But there are some standards that have to be followed, and the Ministry of Health, they know that even if they'll be buying those drugs, they have to follow some specific standards and guidelines which have been set by the Ministry of Health. Now, the Ministry of Health proposed, they have said that they are going to only purchase priority essential. You know, we have health products and technologies, and then we have essential health products and technologies, and then we have priority essential health products and technologies. Now, they are going to come up with a priority list from the essential products, and from this priority list, they are going to supply these drugs. For example, malaria. You know, most of these sicknesses that form the top up in the disease burden, they are going to ensure that those drugs are available and they are of the highest quality. So, KEMSA will do that. But the county governments now, they can purchase all the other drugs, whichever way they want, but also at the same time the Ministry of Health has developed guidelines that they will use. So those guidelines, they will be attached to this guideline that I've developed here. Now counties, okay, I've talked about them procuring their own medicines and drugs. Now the allocation of resources for health, human resource for health infrastructure and equipment will be based on the current norms and standards. But also I want to put in a rider here. They are currently also revising the norms and standards. But before they revise, and I know it will take some time, the allocation will be based on what they currently have. They'll be doing the upgrading on what they currently have. Yeah. So recruitment of staff and hiring of staff will be done by county governments. We know that. And the county governments now, their role is to ensure that they formulate staff retention policies, especially in the marginalized areas. Such policies include incentives such as better housing, better allowances. They should also allow health specialists to work across counties, not to limit them to counties. You know, those small things, to make them as mobile as possible. That's what the Ministry of Health staff even provide choppers if necessary. If there's a surgery, maybe need a neurosurgeon in Garissa, should be able to chopper to lift the person to Garissa to perform there, you know. So just to facilitate, to make them to be able to perform all their specialist functions that they need. Now, the health infrastructure, I think I've already mentioned that. The purchasing of hospital equipment. Now, this one also to be based on a policy, standard and guidelines that are prepared by the National Health Office. They are supposed to be doing this, but now the way now, by March, it's supposed to be devolving. They're supposed to come up with some standards and guidelines that will guide the county governments to purchasing of hospital equipment so that it is standardized. Because we know that if we leave the county government, they may not have the expertise to actually know what is needed to avoid buying obsolete equipment or technologies. So they'll be revising this annually. They're also preparing their own guidelines, which will be attached to this main guideline. Equipping of health facilities will be guided by the level of care and service of that facility. So in conclusion, these guidelines are expected to provide a standard, efficient, and transparent framework for allocation and distribution of health resources across counties. All the other MOH guides on purchase of health products, equipment, revised norms and standards can be added will be added actually or attached to this guide to form a health sector manual or handbook for county. Now, when I was doing this, I realized there was a lot of gap, especially on devolution, and the Ministry of Health also did not know quite how they wanted to move about this. So this guide was supposed to form some basis or framework for them to even adapt or add other guides which they'll be developing separately. I recently saw that they have something on the human resource for human resource, how they'll be managing, but with this now, they say that it will form a basis for them now to even add or fill it up to the level they want it to go. Thank you.
Thank you very much, Helen.